Now, I welcome all of the participants to the PSA online lecture series. This module we have given it as critical care and intensive care in anesthesia or overall critical care module. So I welcome all of you, and this is a series of lectures in which we already have had one lecture 3 weeks ago where Dr. Sadhu was present, and he spoke on nutrition in ICU. And today we have Dr. Arshad Taqi, who would be speaking on ICU quality indicators in low and middle income countries. Dr. Arshad Taqi is the consultant anesthesiologist and critical care, currently associated with Call Associates and Indus Network Hospital of at Lahore. And he has also been the director of basic courses as well as the past president of PMC. So I welcome Dr. Arshad Taqi again. And sir, please, you can continue from now onwards.
Assalamu alaikum, and thank you for this opportunity. I thought we all generally share when we during these lectures on the clinical aspect, on management, various aspects of patient care, patient management, and we get some brilliant lectures like the ones Saad gave. So what I'm going to do is talk about a broader subject. And the basis of this talk, my inspiration for this talk was our experience with Price Registry and one of the first retreats that we held for Price Registry, which is Price ICU Registry, and I'll talk a little about that. But the other inspiration was this article from the Lancet Global Health Commission. So they came up with this article in 2016, I think it was, which talked about high quality health systems in sustainable development goals area. So they labeled it Time for a Revolution. And in the preamble, what they suggested was that the care that people receive in particularly in low and middle income countries is often inadequate. It's of poor quality, and it actually may end up causing harm. So in terms of dollar value, the people are not getting what what the society is paying for in terms of healthcare. What they have shown is that the poor quality healthcare is the bigger barrier to reducing mortality than insufficient access. So it's not that the amount of harm or the barrier to reducing mortality, which is lack of access to healthcare systems, is less of a problem than the poor quality healthcare that they receive when they are in their healthcare establishments. And what they've also suggested is that by improving the quality of these healthcare systems, you could actually save 8 million lives per year and prevent about $6 trillion in economic losses. That is according to the estimate of 2015 alone. So what the data showed from this Lancet Commission shows is that the deaths that are attributed to healthcare are 60% because of poor quality healthcare and 40% because of lack of availability or non-utilization of healthcare systems. So this is the magnitude of the problem. This Lancet Commission actually deals with all healthcare systems, but it holds true and particularly true for high-end healthcare systems like critical care. So what we find in our own country is that over last few years or last couple of decades, there's been that increased sensitization to the need of having ICUs in the hospitals. We have a lot of facilities which have what we call or label as ICUs. some are actually functioning ICUs, some are functioning well, some of them are ICUs in name. So we need to have a way of measuring the quality of ICU. So for that, in order to measure the quality of care in the ICU, you need to develop some kind of indicator. So if you want to say whether an ICU is good or bad, you need to have some kind of measures to say so. And a lot of people have done a lot of work on developing what they call as quality indicators, which means those things that you can measure, which can differentiate between a good ICU or a bad ICU or a functional ICU and a not so well functioning ICU. So we need to understand what are those criteria on which those quality indicators are based. The first thing is validity, which means it has to be a valid criteria, which means if you develop a criteria, let's say you say a patient-nurse ratio is a criteria that you measure, that use to measure the quality of care. And you then develop or agree on a certain patient-to-nurse ratio, and you go on and achieve that ratio. As a consequence of achieving that ratio, one should notice a significant improvement in patient outcomes, which means whatever patient outcomes that you have decided to measure, which could be mortality, which could be number of ICU days, which would be number of ventilator days, or whatever, then getting to that point of indicator should actually improve the outcome. As we get closer to the indicator, the outcome should improve. The second is feasibility, and that's particularly true in case of low and middle income countries, because a lot of indicators, we can have a lot of indicators based on our imagination, which is more of our wish list, but are they achievable? So they have to be feasible. They have to be, if we are to develop a quality indicator for our environment, then it needs to be something that we can achieve. And it should be just beyond our comfort zone to begin with. So if we are within our comfort zone, which means that we're talking about compromising on a very low quality. If we set up our bar too high, then at some point we decide that it's not achievable and we stop bothering. So it has to be just beyond our comfort zone that you can get there. And once you get there, you can then raise the bar and go on. But at every point when you set an indicator, it needs to be feasible, achievable. Third is discriminability, which means that if that indicator, on the basis of that indicator alone, you should be able to actually discriminate between two healthcare establishment or two ICUs which are practicing it, which means, going back to the example of your patient-to-nurse ratio, you can very clearly discern the difference between a hospital which is meeting the target, which means it has got that nurse-to-patient ratio, and a hospital which is not reaching that nurse-to-patient ratio, patient-to-nurse ratio, sorry. So that's the last one is actionability. So an indicator can be used to improve the quality of care and professionals can act on it, which means it actually gives something concrete for the healthcare professionals to achieve. So if we are talking about hospital-acquired, ICU-acquired infections or aspiration or bed sores, then this is something that an outcome which the professionals can act on, take those steps in order to achieve that. So it should not be vague, it should be practical. So based on this background, various quality indicators have been identified. If you go back and look at the literature, there are about 52 different indicators which have been proposed to measure the performance of ICUs. Most of them were developed came from the literature that was coming from the Western world, from countries which had a lot of resources, which was dedicating a lot of resources, trained professionals and everything. But according to one of the proponents of quality, one of those earlier papers suggested dividing these indicators into three main domains. And those domains, Lancet Commission once again has adopted those three domains, that method of classifying the indicators, and they are the foundation domain, the process, and quality impacts. So what are they? When you say for foundation, you need to define the population that it is serving, the governance structure, which means, is it an open ICU or a closed ICU? How does the governance structure run? What kind of a platform is it? Is it a specialty ICU? Is it a general ICU? Then what specialty is it serving? Is it a private sector enterprise or a public sector enterprise? Pay model, pay for service model, what kind of model it is? The workforce, what kind of workforce, which means the ratios. Is it being served by the specialist? Is it being served by journalists who are also part-time critical care physicians? What kind of cover do you have? Are the doctors who are the residents covering their trained ICU residents, or are they residents from the specialties who are doing their rotations at the workflow? What kind of nurses are the nurses ICU trained or the general nurses? What kind of training? What kind of certification process? So that's what kind of resources are being allocated to the ICU, which means in terms of equipment, the number of beds, the bed space, all that. So all these actually fall into the domain of foundation. So you can develop various indicators based on the foundation domain, and we'll talk about that. Then there are those process domain. The processes are the processes of care, which means a process of care could mean the care bundles that you're adopting, the different ways of doing things. This could be central line bundle, your prevention of pneumonia bundle, and all those bundles, various bundles. So what kind of processes? What are the process of handover? What are the processes of documentation? So all that. What are the processes of dispensation? So all those becomes a part of processes. The third domain is the quality impact. That's what we are really interested in. But then if you start measuring the quality impacts only and not really focus on the processes, then you may actually get different the same quality impacts in terms of outcomes, just because you are serving different kind of populations. So of course we understand that at the end of the day, we are interested in the outcomes. Outcomes is what matters the most. But the important thing is to also focus on the impact process. Sorry. So in terms of impacts, you need to have better outcomes, which means whatever outcomes you have decided, you should be able to actually notice an improvement in the outcome. Another outcome that is generally not measured in our ICUs and generally not cited in our studies is the confidence of people in their healthcare systems, which means if people find that their outcomes improve as a consequence of visiting a facility, they start going there more often. Their confidence in the healthcare system improves. And the final quality impact that we should be measuring is the economic benefit that you get out of that ICU, what we call as a dollar value. Depending, and that's where the context becomes important, because in low middle income country, you can develop a transplant ICU that deals with like transplant patients. You could be allocating lots and lots of resources on it. You could be saving 1,000 lives in a very well-functioning ICU by doing those organ transplants in patients who are dying because of organ failure. But on the other hand, in the same country, you or in the same society or in the same region, you could have people, thousands or millions of people dying of a lack of that basic care. So that dollar value becomes important, and that's why it becomes important to actually make those decisions at the level of the society. So these, keeping these in mind, keeping the needs of the society and these domains in mind, and also knowing that most of those quality indicators have come from the West, for which are working in a different context, it was realized that you need to have your own indicators that are valid for low and middle income countries. So this collaboration for research implementation training in critical care Asia Africa, which is CCAA, held what they call as a focus group. They brought in experts working in low middle income countries from various regions, representing all these regions of Asia and Africa, which generally categorized as the relatively poor countries or middle income countries, and took them through a process of what we call as Delphi technique. So in a Delphi technique, what you get is you get those 51, whatever odd 52 indicators, and you put them up and you classify them according to the domains as we've discussed previously. And you ask those experts to independently, without discussing anyone with other person, on what they think are the, let's say, the 10 or 15 most important indicators that are valid, that are have all those features that we actually discussed back here, which means validity, feasibility, discriminability, and actionability. So they would come up with a list. Each person comes up with the list, say they go through the list, and then they give an opportunity for each person to stand up and defend or advocate the indicators that they have proposed. And then they go back for a second round of voting, and then they go on. This process goes on in generally in an ideal situation till the time you reach a consensus of those indicators. So having gone through this process, this group then came up with a list of indicators which are generally proposed for and thought to be ideal for lower and middle income countries. And we are going to go through those indicators in those three domains, which means, first of all, the population domain, the foundation domain. As I said, foundation has got more to do with the structure and of the establishment. So the first domain that they indicator that they proposed was patient to nurse ratio, which means for them, it meant the number of trained nurses or technologists per patient per 24 hours. So for each 8-hour shift or whatever, you need to have a certain ratio of nurse to patient, which then added up to how many nurses. Like if you had one patient to one nurse per patient for an 8-hour shift, then you would require 3, and taking into account the leave and all that, 4 nurses per patient. Second was intensive staffing to bed ratio. Intensivist staffing to bed, which means how many full-time qualified intensivists did you have per bed? Or how many beds was a qualified intensivist managing? It could be like some full-time intensivist managing a 12-bedded ICU or an 18-bedded ICU, or we could have a roster of 3 or 4 full-time intensivists managing those 18 or 24 or 12, whatever bed ICU. And here, mind you, you have to actually then strike a balance between your what it would be that ideal and what was the possible, and what was that optimum level that you were looking for in that particular ICU. Then the next indicator is level of ICU experience of nursing staff. So percentage of total nurses who actually have a qualified nursing qualification for ICU. So you may have 1 out of every 4 nurses qualified ICU trained, or 1 out of every 6, or 1 out of every 2. So that depends. That is another indicator. Then the next most important quality indicator is ICU medical night coverage. So who is covering the night? It generally, in all our ICUs, is a non-consultant doctor who is being supervised by an on-call ICU consultant. But so you could also, or in certain ICUs, you may actually have more than one doctors covering. And in some of those very high-end ICUs, you may actually have a consultant doctor covering the ICU. Then the next is availability of continuous oxygen, SpO2 monitoring, non-invasive blood pressure monitoring in all ventilated patients. Now, this indicator, you don't find it in any one of those previous literature which is coming from the West, because they take it for granted. They take it for granted that any ICU that is an ICU will have all this and more. But we realize that in our countries, we have a lot of facilities which are functioning as ICU, as they are taking critically ill patients and managing them, but they do not have access to all these monitors. But what this proposes is that this should be there as an indicator, and it should be measured, and a lack of it could actually have an impact on the quality. The next domain is the process domain. The process domain deals with competent care and positive user experience. So it's not just what kind of care is being provided, it also means how does the user feel about this experience. And this, once again, is something that we hardly find people emphasizing on. Most of our indicators would not take user experience into account. But please remember, it's not just that patient came and patient got well and left, but what was the quality of experience? So that the ones that they have proposed is duration of mechanical ventilation. So you measure the length of mechanical ventilation support greater than 2 weeks or greater than 10 days if transitioning to tracheostomy for weaning. So anything more than 2 weeks means becomes a quality indicator. The patients should be weaned off or taken care of within that period. Too long stay actually may be indicator of the type of patients you are taking, but then it also can be a quality indicator. So incidence of nosocomial bloodstream infection. This includes the percentage of patients who fulfill criteria for MBSI as a percentage of all patients. So if you got like 40 admissions in a month or 60 admissions in a month, and 3 out of those actually get a nosocomial bloodstream infection, then that it has to be measured either against its own performance over time or performance of other standard ICUs of the similar quality. Then there's a pressure injury, which means pressure source. Number of patients available pressure source is another quality indicator. And finally, what they propose is the incidence of ICU-acquired drug-resistant organisms, which is DRIs of interest. So if the patients are developing drug-resistant organisms in an ICU, that's another ICU indicator. So what they propose is that if you look at these 4 indicators, what you find is that each one is feasible. You can actually measure it. Each one of them actually impacts the patient outcomes. Each one of them is feasible. Also, give something that the healthcare providers can can try to achieve. You can achieve reducing the duration of mechanical ventilation. You can try and taking certain measures, reduce the incidence of nosocomial infections, pressure injury, and drug-resistant organisms by antimicrobial surveillance and uh, those techniques. The final indicator is the quality impact. And impact includes better outcomes, equitable distribution, confidence of people in healthcare systems, and economic benefits, as we discussed earlier. So what they propose is that you should be measuring the number of patients discharged from ICU due to lack of funds. Now, this once again is a novel indicator. This is not found in our literature. But what we find is that in ICUs, most of a number of our ICUs, which are in the private sector, the patients have to leave because they run short of funds. So if that is happening too frequently, then we have got a serious problem. That the ICU may be of very high quality, but then if it is so expensive that it becomes outside the reach of virtually most of the people, then that reflects on the quality. So incidence of nosocomial bloodstream infections actually is also measured as an outcome. ICU length of stay. Now, length of stay, crude length of stay is not a very good measure because the length of stay is impacted by the type of illness and also the patient's Apache score. So most of the time, they actually measure Apache. They measure length of stay based on compare them for similar kind of cases. And the final one they proposed is risk-adjusted ICU mortality. Sorry, this is the one which is based on patients and pre-existing health quality, quality of health, and acute illness and intensity of acute illness. So these are those indicators. So we talked about the 3 domains and the indicators that were proposed by this group that should be measured in our ICUs. Now, it's easier said than done. Why? Because I'll go back to, let's just talk about the barriers. So the biggest barrier is our healthcare business model, which means you are either dealing with the ICUs patients in the private sector or you've got your ICUs in the public sector. The private sector is a pay for service model, which means the more patients you admit, the more you can charge them. There, once again, there is an emphasis on productivity. And because of that emphasis on productivity, sometimes you take more patients than you can handle. And that starts impacting the quality of your service, or that can impact some of those indicators that we've talked about. But if we want to go back and insist on measuring those indicators, the establishment, it may actually become counterproductive for that business model of that private organization which is serving those, running those ICUs. So they may say, fine, these indicators are nice, we love them, but then who's going to pay for them? Because that adds so much to our cost and the patient is not willing to pay so much, so you are making a compromise. The public sector is always limited by the scarcity of resources because we simply have too many patients and we've got too little resources. So that's where, if you really want to implement these indicators, you need more resources, and that's where it becomes a non-starter in itself. The second important barrier is the lack of accountability. We don't have a culture of accountability. What we think about when we talk about accountability is like what we find on the media and the social media, which means one odd poor outcome, one odd unlikely outcome, and suddenly you make news, and suddenly there's that storm rising. Every organization starts chasing that. Every organization and every advocacy group starts chasing you. That's not accountability. Accountability is a sustainable, is an ongoing process where you are continuously measuring your outcomes and continuously measuring your processes, and somebody is auditing them for you. So there's external checks and your own internal accountability systems. So that culture develops over time, and we in the lower middle income countries mostly don't have that kind of culture, and partly is because of that business model and the emphasis on productivity only. And then there's that lack of regulatory oversight. So who are our regulators? Here is an example of your production pressure, which means this price registry our price registry showed the number of ICUs and the number of area hospitals with the ICUs where you have access to ICUs. So we simply have too many patients, and that actually adds to the pressure on our ICUs. This also was looked at in another study wherein they looked at the barriers to accountability. And what they showed was that burden of data collection, which means you've decided that you're going to measure all this. How are you going to collect all that data? Because that collecting data is a resource intensive thing. If you want to compare the quality of 3 or 10 or 15 different ICUs, then you need data from all of them. And most of the data in our ICUs that do not have those electronic systems is based on those charts, and retrieving that data becomes extremely difficult, very time consuming. Then there is this absence of standard definitions. So that's another huge barrier, and the ability to replicate the data. Once again, the availability of source data, fear of publicity. So if I stand up and say that this is our ICU mortality, we will actually be getting negative publicity because people would not be looking at those 60 or 70% or 80% patients who have survived, but may be more interested in looking at those 20% who died. So nobody wants those 20% to be highlighted and talked about, because that becomes a major deterrent. Fear of benchmarking. Once again, if you want to implement certain standards, you then benchmark. If you say you need to have that much risk-adjusted mortality, then you need to have a benchmark. And once you have those benchmarks, then the others are supposed to get there. And if they don't get there, they will be considered as low quality, which is the object, of course, purpose. But any hospital which is not getting there would be very reluctant in joining this process of quality assurance. Once again, accountability is once again a major barrier to implementation of those standards. And the other is fear for future pay for performance. So if I was an ICU running on as a private sector ICU, and I start publishing my quality indicator data and start gathering that data and sharing it, I would be wary that people then stop coming to my ICU because there's that public data available which says that my ICU is inferior to ICU X. So then the solution proposes that the hospitals, institutions should be encouraged to participate in quality improvement programs. You need to have mandatory data collection, uniform data collection. You're measuring the same thing. And that data is collected by an external source instead of your own internal. And the hospitals get a regular feedback on, the ICUs get the regular feedback on their performance. And electronic data and electronic data extraction is another way of ensuring to removing the barriers to implementation of quality standards. So how do we really go about implementing them? First is to create a tool to gather data, because if we expect every ICU to generate their own data and then pool that data in order to actually define what is normal, what is the standard, create those benchmarks. That would be a huge task. So if we had a tool, which means have a platform where everybody's going and pooling in their predefined patient data, and then it becomes so much easier to actually then compare the performances. It becomes a lot easier to develop the benchmarks and all that. Once you have that tool, and once you know you can create those quality standard and record the data and benchmark and audit, then the next thing is to actually go on and get it done on practically. And for that, you need people who are willing to advocate for this. So who's going to advocate providing high quality ICUs, running high quality ICUs? I think more than anyone else, it should be the healthcare professionals. Because mind you, the world with the social media and all that, people are becoming more and more informed. Sometimes that information may not be exactly correct, but based on the information they get globally, they can tell what the standards are out there. So if we don't correct ourselves, if we doctors don't create those tools and advocate and bring change from within, somebody from outside is going to force that change on us. And then that change may not be feasible, that change may be asking too much, that may be accompanied by penalties which are not acceptable to us, and that could disrupt. So we people, we healthcare professionals, we critical care physicians should actually be advocating implementation of those quality programs. The healthcare establishments also should be advocating them, because it is also in their own interest to have a reputation as a safe ICUs. The regulatory authorities have a big role to play, and regulatory authorities should not only develop those indicators, they should inform the establishments again about those indicators, and then they should put in a mechanism to use that data to actually tell the difference between the hospitals which are achieving those benchmarks and those that they are not. So in order to gather the data, and I must give credit to Dr. Madhya Hashmi, who single-handedly was responsible for getting Pakistan on the map of this ICU registry. This was developed by, or this is an initiative of, I think, the Oxford Foundation with financial assistance from Wellcome Trust, and they developed these ICU registry for low middle income countries. The Sri Lankans were there; they had all their ICUs mapped when we started the project in Pakistan, and this data is from 2019. I think that was when the first report was published. And there we had something like 71 ICUs in Punjab, 35 in Sindh, 12 in KPK, and 2 in Balochistan mapped, with the number of beds like 916 for Punjab and 484 for Sindh, and smaller number for KPK and yet smaller number for Balochistan. So we actually through this registry managed uh, to map the ICUs, at least the ICUs which are willing to provide participate and provide us with the data. Some of them did not, and they became recruited later. But this is the number of beds that were recruited. And then there is this breakup of what kind of ICUs they were and all that. And then there is this, pardon me for this very crowded slide, which actually talks about the resources, which means how many of them, what percentage of them had piped oxygen, how many of them had wall mounted units, how many of them had piped medical gas air, uh, how many beds per ventilator, and all those rest of those indicators that are already being measured. So this data was, I think, back from 2000, our first study in 2019. So this is just a view of the dashboard of this registry. So if you are a participating hospital, you participating ICU, you get your access, you have your own kind of access to the beautiful thing about this registry is that your data remains your data confidential. So only an institution has an access to their data. However, that when that data is pooled, it becomes anonymized, which means the data all the data that goes from the hospital where I am contributing, once it joins that pooled data, then that becomes you can't tell which is coming from where. So that's the beauty of it, because it then maintains that confidentiality and institutional confidentiality. So these are some of those figures that you are getting from the price registry platform. Now coming to the regulators. According to after the 18th Amendment in Pakistan in 2011, I think, or 2010, 9 or 10, 9, I think it was, that 18th Amendment, after 18th Amendment, the delivery of healthcare became a provisional responsibility. So at the federal level, you were only regulating the practice, which means the licensing of the doctors, higher education was actually became a federal subject. However, actual care delivery became provincial subjects. And after that, in 2010, healthcare establishment or healthcare commissions were formed in all 4 provinces. They are at various stages of development in all those 4 provinces. And they've all actually developed service delivery standards. But when I went on and looked at the service delivery standards of Punjab, they had still not developed the ICU standards. More recently, we had 2 meetings, which were in which they involved major ICUs in the country, in the province, and brought them in and asked them to develop those, agree on those standards, which would then healthcare commission will adopt, and they have got the legal kind of power to implement them. KPK also has got a set of very good minimum service delivery standards, which is the same as quality indicators, another term for it. But they are once again, and the beauty of it is that their healthcare, their indicators actually have a lot to do with the process. Where in the Healthcare Commission, Punjab Healthcare Commission indicators are focusing more on the foundation or the structure of the ICUs. KPK indicators have a lot of emphasis on the process. And some of the crude outcomes, which means mortality and all, but some of the other outcomes which could actually impact the care delivery are missing from that. So you have the healthcare commissions, which are now being more and more sensitized to having quality ICU care and actually implementing, developing, informing people, and then implementing those ICU quality indicators. So we may actually uh, be seeing more of this, and some some of those indicators that I talked about are actually under discussion, at least in Punjab Healthcare Commission. So that's my part, my bit on the quality indicators in low and middle income countries. And just to reiterate, I'll just go back and quickly go through the list. So in terms of the structure, the actual platform, actual facility, you should be measuring the patient to nurse ratio, then intensivist staffing to bed ratio, level of ICU experience of nursing staff, ICU medical night coverage, and availability of those certain uh, equipment which are mandatory for patient care of critically ill patients. And then the processes that should be measured include the duration of mechanical ventilation, uh, and those no, nosocomial bloodstream infections, then pressure injury, and DRIs. And in the outcomes, impacts or outcome, you should be measuring the number of patients discharged from ICU as a percentage due to lack of funds, incidence of nosocomial bloodstream infections, ICU length of stay, and risk adjusted ICU mortality. So these are the proposed indicators. Of course, you can go on and develop your own indicator or propose your own indicator which you think actually is feasible and all the rest of those qualities that we talked about. So you could propose any indicator based on this criteria, which means valid, feasible, discriminatable, and actionable. With that, I will actually end my presentation. It's just that what I believe is what Vincent von Gogh said, I'm seeking, I'm striving, I'm in it with all my heart. So if we put our heart into it, I think we can give better ICUs and better ICU care to our patients. Thank you.
Thank you so much,
I'll be happy
Dr.
to take any questions.
Yes, thank you so very much for the quite a different topic. Usually, we do have the topics in which the residents get benefited for the exam purpose, but I think this topic of today is far more important than the topics because I'm sure that in the future they will learn more when they will get senior and they might come to a certain position, faculty position, where they can actually get the things right in the ICU and in their hospital. So we have
Or else, sorry for interruption, we can actually convince people to include this in the exam.
yeah, that's quite reasonable because most of the times we do follow whatever is written in the books and we tend to forget and we tend to follow those topics even and where the ICU indicators or even how to set up a proper or how to lead a proper ICU is given. We don't even follow that, and I've seen. I personally I don't do ICUs, but because surgical ICU is affiliated with the anesthesia, so at times we do have to do that. So we have a few seniors in the participants list, in which we have Dr. Kashif Mehman, we have Dr. Maqsood Ahmed Siddiqui, who's currently working at Sakhar, and we also have Dr. Shabir Jumani, who's working at a private hospital. So I would request them to unmute themselves, and I would just want to have a few words from them on the basis of the ICU care and what exactly can further we can add on, and then we can take the question from the participants. Dr. Shabbir, and we also have Dr. Amjad Ali, who has joined us from Quetta. So I would request all of you one by one. Dr. Shabbir, you can please go on.
Well, very true. It was a very good presentation, and Professor Arshad Taqi doesn't need any comment. Actually, we all I require is just a compliment him and thank him for presenting very good data for that. As far as private sector is concerned, particularly in Karachi, where we work in private hospitals, the ICU care is very, very costly and very, very expensive, and sometimes out of the reach of many patients. This is the main problem for us. But anyway, we try to keep the standards of intensive care as much as possible, by collecting funds and things like that. But again, there a lot has to be done, particularly in the private sector to develop the ICUs. So there's a lot of pressure on public sector ICUs everywhere in Pakistan. Karachi is no difference at all. The main thing is,
Sir,
yes,
sorry.
please.
No, please go ahead.
The thing is that the corruption and other things, financially particularly, they hamper the funding of the public sector hospitals. The private sector, is doing a lot, but again, something has to be done to regulate the private sector as far as funding is concerned and the finances are concerned. Anything, if somebody wants to ask me about private sector, I'll be available to answer.
Okay, thank you, Dr. Jabir, for your comment. Dr. Arshad, would you like to? I don't want you to answer actually, basically, because whatever Dr. Shabir has just said is quite reasonable in the sense that yes, we do see such kind of disparities and discrepancies between the private sector and the public sector ICUs. Reason being that we do have limitations in the in the private sector, being costly, being non-afford patients getting non-affording, having, along with the other administrative issues which you had mentioned in your slides earlier about the availability of the nursing staff, about the availability of the junior or the senior doctors at the night time, and so many other things. But at the same time, in the public sector, which are the government led sectors, ICUs, we do see the lack of and limited resources in which the doctors, even though they want to do things and they want to work, they have limitations. So do you have any comment?
I think the problem lies with the business model, the way the society is structured. And I see the thing is that unless we look at the thing holistically and look at the basic foundation on which our healthcare system is formed, these core issues would not be addressed. They'll persist. What happens is that people have to go to the doctor when they are unwell, and they have not planned in all their. They plan their daughter's wedding. They plan lots of things, building a house, and I don't blame them. Rightly so, they don't plan. They have not planned as a contingency, which is disrupted health. And the bigger the disruption, which means the sicker the patient, the more expensive it becomes. So this system of pay for service, pay for service, and then payment by the person utilizing that service is fundamentally flawed. That's where the system of health insurance comes in. Yes, there are question mark about that too, but given the options we have, we would ideally, you always start saving for whatever you want to achieve at whatever time. If you want to build a house, you start saving for your house the moment you start get your first job. If you want to get married, you start saving for your marriage. So why aren't we saving for uh, our ill health at some point in time? If anyone is interested, I'll be happy to share a book known as Poor Economics. It's a very, very interesting reading, a very interesting book on this very particular subject. But people are not saving, and I don't blame them. And in good societies, the societies make sure that people have saved through insurance or whatever, and then they don't have to pay at this moment, at the moment they get unwell. So that's where you can actually have those establishments which are paying on behalf of the patient. And then that also means that they will actually demand better money service for the money they are spending, which means they demand better dollar value. Because if you are an individual patient and you got money and you got tons of money and you go to an ICU and that in a very fancy hospital, and that hospital doesn't provide you with the quality ICU, it may be fancy looking and all. You cannot, as an individual, force quality on that ICU because you're just one customer, one patient. It has to be an entity which is bringing in a lot of patients, which can then divide that cost, A, and B, force the ICUs to develop certain quality standards so that they get value for their money. So this is a more, this healthcare economics is an altogether different subject that we generally do not consider. We know that there's a problem, but we have not studied that problem systematically, and we are not, as we as doctors are not becoming a party to discovering the solutions. I'm glad Dr. Jimani brought this up, but then it's a complex question, and we need to rethink and remodel our thinking in order to address that question.
Yes, I quite agree with you, Dr. Arshad. It's point to ponder, we should think about it, there has to be some system, of convincing the general population, to save money for their health. And the NGOs, who are providing service in healthcare center, they should think about it, how to convince the general population, usually these NGOs, they get fund through, rich people, and again, general population doesn't, put any share of them, in these funds. So we have to do something, these NGOs, particularly your NGO, and does something like that. They should think about it, and form a structure or something like that, to collect the funds, through sports per person, through insurance or whatever. I mean, it's just the beginning. That's whatever you have said, and we should actually, come forward, and form some kind of institution or something like that organization. We can start this work. We can think of it.
Yes, you
I
are
don't know.
absolutely right, Dr.
Yes,
Shabbir.
I don't know.
Actually, I think Dr. Dr. Arshad, along with Dr. Madia, who have started the price registry, which Dr. Arshad Taqi has earlier mentioned in his talk. I think that registry is again a marker of looking at things differently and to get the things done. Instead of just always talking in conferences and on the lectures and different mediums that nothing can be done in ICUs. I think these indicators, these parameters would help all of us in general to go towards a good ICU care, if I'm not wrong,
Yes.
Dr. Arshad.
Agree with
Sure. But here's a question, I think, which is not exactly the part of the discussion, but of course, relevant. I'm working in a hospital, which is GIMS hospital. But what measures or indicators should be taken to decrease rate of sepsis in ICU? Now, decreasing the rate of the sepsis, start with something as simple as hand washing. I mean, so basically, reducing sepsis, you got various care bundles to reduce the risk of infections. You reduce the risk of nosocomial infections. You are actually reducing the risk of the patient developing sepsis. You have your antimicrobial protocols. You are reducing the risk of patients developing resistant blood infections and sepsis. You pass your central lines using proper techniques. You wash hands between patients. So all those simple steps. uh, I think this is the one of those um, one of those interventions which require less resources. Of course, resource becomes important in one way, that if you got one nurse looking after too many patients, then that is going to ultimately lead to some kind of compromise on the uh, their asepsis. But otherwise, what it requires is some very simple interventions, which means you use aseptic precautions while you're breaching the barriers. You take aseptic precautions when you're moving between patients, hand washing, your gowning, your gloving. Uh, those little things are important. Then going on to more advanced things, you're ensuring proper air circulations, proper filtration, positive pressure. So all those measures are important.
Sorry for interruption. I quite agree with you, Dr. Taqi. This is the main thing. By adopting these aseptic precautions, they don't cost anything. In fact, they save the cost, of future complications. So basic training should be, adopting these type of things. It will save a lot of money. I agree with you.
So we are also open to other participants for the questions. Thank you, Dr. Shabir. Do we have any other questions? And we also have other participants as Dr. Amjad and Dr. Maqsood. We also have Dr. Mohammad Akhtar Waid Khan Sahab. If anyone wants to have a comment, please do share your experience.
Assalamu alaikum.
Assalamu alaikum. Dr. Amjad, yes, please.
Thank you, Dr. Arshad. Actually, it was a very beautiful article. And actually, I gone through this article a year before, but actually, I couldn't apprehend it properly.
Sorry, I'm interrupting you. Dr. Amjad, your voice is echoing. If another voice is open, can you please mute one of the voices or the chat boxes if you have two? Your voice is echoing.
Is it clear now?
Yes, much better. Thank you.
Okay, actually, I was saying that I gone through this article a year back, but I couldn't even comprehend it properly. But this time, I understand it very well. So there is actually saying by Shiv Khera, if you are not part of the solution, you are the problem. So actually, we are also part of this problem. So my question is that what are the role of our societies like PSA and role of CPSP? In actually they are establishing in standards, because many times they are accrediting the institutes, so we don't have any established standards that which institute should be accredited. And second, after accreditation, what is the role of monitoring of that accredited institutes? Because you are also a president on the PMDC, so you are very well versed with the regulations and also the regulatory bodies. Thank you.
Thank you for asking. I think that's a very important question. See, Dr. Amjad, I was a part of the regulatory body, and that I had learned something. The most important thing I learned is that rules and implementation of rules is only possible when you have more than 80% of the society or stakeholders convinced about the benefit of that rule. Then you can force it on the other 20% who are not compliant. So first of all, I think before we start making rules and trying to implement that, forcing the implementation of those rules, we need to convince people that it is in their own interest. And I hate to say that, but man is a selfish animal. So unless we realize that it's not just in the patient's interest to have high quality intensive care. It's in the interest of us professionals as well to have high quality intensive care or deliver quality services, because that will kind of ensure the society's trust in our systems. And it's very important to have that trust of the society. So in order to implement it, I absolutely agree that TSA has a great role to say. Once again, CPSP can go on and de-recognize a program for not being compliant to the those standards. But then if there's that one odd hospital or one odd department which is not compliant, CPSP can go and close it. But they cannot go and close 80% of the facilities because of non-compliance. So mind you, unless we are first sure that we want the implementation of those rules, nobody's going to come in and force it on us, because even if they try to, they'll fail. That's a lesson that I learned the hard way as a regulator, that if the people on whom you're trying to implement the rules are not really willing to implement them, then eventually all of them getting together will actually force you out. So works fine because they are happy doing it the way they are doing it. And so unless you have backing of the society, it doesn't work. So our emphasis should be on the education. And I think PSA and these societies and critical care fraternity, it is our responsibility to inform public about and inform the other healthcare professionals and people practicing about the value of implementing these standards. I hope I have explained it correctly.
Yeah, exactly. And we have to work on this. So this is a not responsibility of single person. Actually, it should be all the members who are with the PSA. So we should come forward and work on it. Thank you, sir. Thank you very much.
Thank you, Dr. Amjad. Any more comments and suggestions or questions from Dr. Arshad Taqi? So I think with this, we will conclude our session. Thank you so much, Dr. Arshad Taqi, for such an insightful lecture. I'm sure that it would have opened up the minds and the eyes of other participants who are actually not in the capacity of obviously making the changes as administrators, but even this also shows that even if you are working at a residence capacity or as a trainee RM, or you're working in ICU, even if you follow simple indicators, then even then a patient can be saved, or quality care can be given to patients. We, Dr. Akhtar, would you like to say something? Because I see your mic unmuted.
Oh my God, what should I say about Arshad? Right from the very beginning, when he was not even had talked about Madhya Hashmi, I remember at that time I was an active participant, and she had a full access of my ICU where I was working at that time, and nothing was hidden from that. Now, Arshad, I would like to point out to you,
Yes,
at one time in my professional career, I suggested that we should have mortality and morbidity conference. Let it be closed affair of that hospital. But nobody in the hospitals in Karachi where I worked, they agreed. Can you give me the possible reason why they didn't agree? Because if it's a closed meeting, then at least we can sit down and rectify what went wrong, who was that wrong, who did not perform the duties well, and this and that, whatnot. What is your opinion? This is number one. I'm very glad about one thing that I can see now. Now I'm a retired person since 2020, but you are there to carry forward the things. So good luck to you for your future. And I think I can still travel by air. So this place where you are working now, and there, I should come to and meet you there. What do you say about that?
Thank you, sir. Coming back to that's you. So you've always been you. You know you were my examiner, and I know you are my teacher. And getting a compliment from a teacher is the best reward that you can get. But coming back to your question, the first one, why don't we have those morbidity mortality meetings, or what? And I'll take it a step further. Why don't we conduct audits, and why don't we share our audits and have an honest kind of see? It's just a question of developing that culture. Uh, I think it's not that we are trying to hide the things. It's just that sometimes we are lazy, or sometimes we've not really started focusing on the value of doing a thing. I think I'm sure the next generation is going to do better than us. They are more sensitized, they are more informed, they have access to more information, and hopefully that should start. Because what I find is that there are more hospitals now contributing to ICU registry, and there's a lot of data coming from ICU registry as well. So I just hope that this will become a norm in the days to come.
Good.
Thank you so much. Thank you so much on behalf of PSA Karachi, Dr. Arshad Taqi. It always is an honor to have you on board and to have you to listen to you as a lecturer. We would also like to have you later in our other sessions. And I would request all the participants who are remaining here, kindly fill in the feedback form so that you can get the e-certificate. And we hope to see you again after 2 weeks, inshallah, on regular basis from now onwards till August, and afterwards a new module will be started, which most likely will be on pain management. So thank you everyone, and thank you so much Dr. Arshad Taqi, Dr. Akhtar Waid Khan, Dr. Shabir Jumani, and Dr. Amjad for joining us, and all the senior members along with the participants. Thank you and have a good night.
Always a pleasure, and thank you very much. Allah Hafiz.
Allah Hafiz.